Encephalitis is an inflammatory process of the brain parenchyma, which usually presents with fever, headache, and mental status changes. The term encephalitis is when meningeal inflammation is also present. Encephalitis is usually an acute infectious process, but it also may be a post-infectious autoimmune part of a systemic disorder or the result of an indolent viral infection. Encephalitis may be diffuse or localized organisms, cause encephalitis by one of two mechanisms: or direct infection of the brain parenchyma via an extension of meningitis secondary to viremia, or retrograde spread via peripheral nerves, or to a post-infectious immune-mediated response in the central nervous system that usually begins several days to weeks after clinical manifestations of the infection. Viral causes: enteroviruses, paraexoviruses, herpes simplex viruses, arboviruses, west nilovirus, Japanese lacrosse powassin, and equine encephalitis viruses, cytomegalovirus, human immunodeficiency virus, rabies virus, varicella zoster virus, influenza virus, mumps virus, measles virus, encephalitis, JC virus, lymphocytic choriomeningitis virus. Bacterial causes: Borrelia burgdorferi, Bartonella henselae, Mycoplasma pneumoniae, rickets, hepatitis, causes Plasmodium falciparum, Naegleria fowleri, Acanthamoeba speed, Felis ascaris, amoeba, Bartonella henselae, Mycobacterium tuberculosis, Mycoplasma pneumonia. Fungal causes: Cryptococcus neoformans, Coccidioidid species, Histoplasma capsulatum. Other causes: prion disease, lactobacillic, toxic, and neoplastic disorders, idiopathic types of encephalitis. One acute disseminated encephalomyelitis. This is the abrupt development of multiple neurologic signs related to an inflammatory demyelinating disorder of the brain and spinal cord. It can follow childhood viral infections or vaccinations and can clinically resemble multiple sclerosis to autoimmune encephalitis. This is a form of encephalitis in which specific gaudy antibodies such as anti-methyl D-aspartate receptor and anti-and oligodendrocyclicoprotein antibodies are directed to brain antigens. It is a relatively common cause of encephalitis. The presentation is often subacute with psychologic manifestations: cortical dysfunction, movement disorders, autonomic dysfunction, and seizures. Epidemiology: arboviral and enteroviral encephalitides characteristically appear in clusters or epidemics that occur from midsummer to early fall, although sporadic cases of enteroviral encephalitis occur throughout the year. Arboviruses are limited to certain geographic areas, reflecting a reservoir and mosquito vector. Herpes viruses and other infectious agents account for additional sporadic cases throughout the year. In North America, West Nile virus and lacrosse encephalitis occur in the summertime, resulting in a range of manifestations from asymptomatic infection to severe neurologic involvement. Lacrosse virus is found in the Midwest and southeastern United States, whereas West Nile virus is more disseminated across the country. Collects mosquitoes are the principal vectors for West Nile virus, and a broad range of birds serves as its major reservoir. Herpes simplex virus. Encephalitis can occur in neonates with or without skin lesions via perinatal or postnatal transmission. Beyond the neonatal period, HSV encephalitis can result from primary or recurrent infection with HSV type 1. In the immunocompromised host, other herpes viruses such as cytomegalovirus, Epstein-Barr virus, human herpes virus 6, and varicella zoster virus, as well as Toxoplasma gondii and JC viruses can reactivate and cause encephalitis. Fungal infections of the CNS are rare, but can also cause disease in this patient population. Clinical manifestations and symptoms of encephalitis. Emerging stage non-specific symptoms such as sore throat, fever, headache, and abdominal complaint, followed by characteristic symptoms of progressive lethargy, behavioral changes, and neurologic deficits, seizures, maculopapular rash, fulminant coma, transverse myelitis, anorexia, horn cell disease, or peripheral neuropathy. Neonates with HSV, encephalitis, present with fever, lethargy and or seizures. Vesicular skin lesions, typical of cutaneous infection, which may or may not be present. Infectious differentials, bacterial infections, mycoplasma infection, rickettsia infection, fungal infections, parasitic infections, non-infectious differentials, autoimmune, inflammatory, metabolic diseases such as Raynaud syndrome, hypoglycemia, collagen vascular disorders, drugs, hypertension, and malignancies. Note, elucidate a careful history, including immunization record, travel to many regions, animal exposures, and geographic and social risk factors, as these help to establish the etiology of encephalitis in a patient. If the patient is known to be or found to be immunocompromised, the differential diagnosis must be broadened accordingly. Elaboratory and emergent studies, one cerebrospinal fluid analysis. This is done to determine viral encephalitis. CSF findings in viral encephalitis include lymphocytic pleocytosis, a slight elevation in protein content, and a normal glucose level, but sometimes CSF may be normal. If the CSF findings show extreme elevations of protein and reductions of glucose, this suggests tuberculosis, cryptococcal infection, or meningeal carcinomatosis. Complete blood count with differential 3 blood culture. For autoimmune encephalitis, antibodies. 5 liver function tests. 6 infectious serologies. This is done by testing serum and CSF to determine an infectious etiology for encephalitis. Based on the risk factors, serologic studies should be obtained for arboviruses, including West Nile virus, if indicated by the patient risk factor. HIV, Epstein-Barr virus, Mycobacterium pneumoniae, Bartonella henselae, and Lyme disease. Additional serologic testing for less common pathogens should be performed as indicated by the travel, social, or medical history. 7 magnetic resonance imaging. MRI is the study of choice in the diagnosis of encephalitis. A computed tomography, CT, may be used to exclude contraindications to lumbar puncture or if MRI is unavailable. Neuroimaging studies with MRI or CT are often required prior to a lumbar puncture in these children, as they generally have altered mental status. Brain imaging may be normal or may show diffuse cerebral swelling of the parenchyma or focal abnormalities. 9 EEG findings may be abnormal and can show diffuse slow wave activity, although focal changes may be present. A temporal lobe focus on EE or brain imaging is a characteristic feature of HSV infection. 10 polymerase chain reaction. In most cases of viral encephalitis, the virus is difficult to isolate from the CSF. Polymerase chain reaction. Test for herpes simplex virus and Encephalitis, mycoplasma, West Nile virus, and other viruses, 11 viral cultures of stool or throat swabs. These may also be obtained, though they have less utility than rapid multiplex PCR testing. 12 brain biopsy. Brain biopsy is seldom performed and is generally recommended only if the etiology remains unknown and a patient continues to deteriorate. Rabies, encephalitis, and prion-related diseases may be routinely diagnosed by culture or pathologic examination of brain biopsy tissue. Brain tissue can be sent for pathology, culture, and PCR testing, and may be helpful to identify arbovirus and enterovirus infections, tuberculosis, fungal infections, and non-infectious illnesses, particularly primary CNS vasculopathies and malignancies. the exception of herpes simplex virus, varicella zoster virus, cytomegalovirus, HHV6 and HIV. There is no specific therapy for viral encephalitis. Management, supportive care, intensive care, unit admission to facilitate aggressive therapy for seizures, monitoring and timely detection of electrolyte abnormalities, airway monitoring and protection, reduction of increased intracranial pressure and maintenance of adequate cerebral perfusion pressure, definitive management to 1 intravenous ciclovir. This is the treatment of choice for herpes simplex virus and varicella zoster virus infection. 2. Ganciclovir is used to treat cytomegalovirus disease in immunocompromised patients. It is also used to treat HF6 encephalitis in patients who are post-bone marrow transplant. These patients can also be treated with foscarnet. 3. Antiretroviral agents. These are used to treat HIV infections. 4. Pneumonia infections. These may be treated with doxycycline, fluoroquinolones, or macrolides. Though clinical value of treating encephalitis associated with mycoplasma disease is uncertain. 5. Acute disseminated encephalomyelitis has been treated with high-dose intravenous corticosteroids. 6. Autoimmune encephalitis. This is treated with steroids, intravenous immunoglobulin, and rituximab. Complications and prognosis complications: paresis or spasticity, cognitive impairment, weakness, ataxia, recurrent seizures. Most patients gradually recover some or all of their function. The overall mortality for infectious encephalitis is low, depending on the etiology. Prognosis among survivors, symptoms usually resolve over several days to 2-3 weeks. Although most patients with epidemic forms of infectious encephalitis in the United States recover without sequelae, severe cases leading to death or substantial neurologic sequelae can occur with virtually any of these neurotropic viruses. Disease caused by herpes simplex virus, Eastern equine encephalitis or pneumonia is associated with the worst prognosis, especially in children younger than 1 year of age or with comorbidities. Can be fatal in rare cases. Relapses of ADEM occur in 14%, usually within 1 year with the same or new clinical signs. Recurrences of ADEM may represent the onset of multiple sclerosis in childhood. Prevention: 1. Avoid mosquito-borne or tick-borne exposures, and 2. Remove ticks carefully. This is the best prevention for arboviral encephalitis. Diffusination, vaccinated against poliomyelitis, influenza, and pre-exposure or post-exposure vaccination against rabies. There are no vaccines in use in the United States for the prevention of arboviral infection or for enteroviruses. There are no specific preventive measures for herpes simplex virus encephalitis, but pregnant mothers with active genital lesions are delivered via cesarean section as a preventive method of spread. Raynaud syndrome can be prevented by avoiding use of aspirin or aspirin-containing compounds for children with fever, as well as use of varicella and influenza vaccines.